Thrilled to have with us here on America Tonight Dr. Mark Souweidane. He is the Vice Chair for Neurological Surgery and Director of Pediatric Neurological Surgery at the Weill Cornell Medicine, Brain, and Spine Center. Dr. Souweidane, thanks so much for coming on with us, because what we're talking about sadly has affected two of my friends' children. We're talking about pediatric brain tumors. And, you know, one of the things, and you would know the acronym better, but DIPG. First of all, for people listening, tell us about DIPG and the severity of that and what happens to these kids. It's like a serial killer.
Yeah, thanks for the invite, Kate, to begin with. And I'm sorry to hear that friends of yours have been afflicted by this. DIPG, diffuse intrinsic pontine glioma, is one subset of tumors in children that affect the brain, and more precisely what's called the brainstem. The brainstem is the, if you will, the relay center between the brain proper and everything that happens below the neck. It's a very vital area, very tight, compact area, where these tumors that, with consistency, kill these children with a median survival of just shy of a year.
Wow. And so you just recently presented the results of your phase 1 clinical trial for the use of a better medication delivery system in these children with what we just talked about, DIPG. So tell us about that.
Yeah, the clinical trial really is a result of a very ambitious effort to improve the outcome for these children. And for decades, and for as long as I've ever known about DIPG or interested in pediatric brain tumors, that the survival curves and expectations were never improved in that 30, 40-year interval. So we embarked on a very adventurous way to be more effective and get in chemotherapeutic agents into the area of interest, namely the brainstem. And it's very well known that when you administer chemotherapy by an oral or intravenous route, that a very, very small fraction of that drug gets into the brain and hence the brain tumors. So the normal routes of administration are extremely ineffectual and inefficient for getting drug concentrations where we want them in the brain of these children. So this design is based on a simplistic idea, and that is directly administer the chemotherapy into the tumor, right? Sounds very logical and simplistic. And why shouldn't we be doing it? Why shouldn't we be doing it? It's because it is a surgical intervention. And you're also embarking on one of the most vital functions or structures of the brain, namely the brain stem. So it's illogical to think that you can place a catheter in the brain stem and infuse volumes of fluid that would be containing the chemotherapeutic agent. So that's what we set out to do. That was the first 15-plus years of my career. And as you mentioned, we reported on our phase 1, or what you'd call toxicity-seeking, clinical trial at the American Society of Clinical Oncology this past spring. And delightfully, we saw that we could do this in children safely with a very, very good efficiency, that we could get 1,000-fold higher concentrations of drug in the area of interest safely without affecting anything in the rest of the body. So the foundation was validated without question.
Wow, that's incredible, because and to really drive this home, as you said, so much of your life has been spent doing this, and we talk about the brainstem. And again, to put it in perspective for people listening, it's just very difficult to get to that area, isn't it, without doing any other kind of damage?
Yeah, there are tumors and lesions within the brainstem that neurosurgeons consistently will go after and remove very effectively. Benign tumors, well-circumscribed lesions, but those differ in that they are focal. Those differ in that they reach the surface of the brainstem. It affords us a route in, and there's a very clean line of demarcation that we can carefully identify at the time of surgery. These tumors, DIPG and other infiltrative gliomas, have that word assigned to them, infiltrative, meaning that they entwine themselves within the normal cellular structure of all the pathways and complex nuclei in the brainstem that make it an impossibility to remove these. And even if one can go in and take out the majority of these tumors, we know that the invasive front has escaped surgical treatment and will recur in those margins. So a much different growth pattern than other lesions that we will willfully go after in the brainstem.
We're speaking with Dr. Mark Souweidane from Cornell Weill. And so in talking about this, I mean, this has got to be amazing, the amount that you're able to measure here, the amount of kind of like a treasure trove of information that you're finding out. Am I right?
Yeah, I mean, what it's done is opened up a huge door of potential. And, whether we have everything right with the phase 1 study is left unsaid until we start looking more diligently at optimal dose and then challenging ourselves to see if we can do better than historical controls. But at this point in time, the exciting component of this is now we've shown we can do this. So this opens up a huge potential with regard to agents that have been left by the wayside because they cause systemic toxicity. Agents that are very promising in the laboratory, but we know they don't cross what's called the blood-brain barrier. So now there's great potential for introducing either old agents or innovative agents. Now there's the potential of integrating agents that were prohibitive from the standpoint of systemic toxicity. So there's a whole wide spectrum of agents that can now be either re-explored or introduced into a tumor that has escaped any element of therapeutic benefit from therapy. So that alone is a huge jump forward in this. And then the other really has to do with the quieting of any cynicism that would be applied to this because it's dangerous. Right, so it's logical to think that you're going to put a catheter in the brainstem and infuse all this fluid and you're going to hurt children, and that doesn't make sense for a child that only has 5, 6, 7 months left of life. Why would you do this? But now that we can do this, and we've done this very safely to the point that we're sending these kids home the following day, and it's been remarkable from the standpoint of the safety element and the drug delivery element. So great capacity here now to interface with industry, with pharmaceutical companies, with investigators across the globe to try and now optimize this.
Yeah, and in optimizing it, one of the things would be, I would assume, right, testing different drugs and combinations?
Yeah, without question. I wish I had 10 lifetimes and 10 more people in my laboratory doing this. Every one of it, and it's challenging, right? I mean, to drive a clinical trial like this, which took us 4 years to complete, and I will say, 15 plus years to lay the groundwork for, with a price tag of foundation money, and we've had very generous individuals and foundations rise to the occasion, just shy of $2 million to drive this trial. Now think about the multitude of agents that are out there that we'd love to experiment with. And you can do a lot of work in the laboratory to screen, but every time you embark on bringing this into a clinical front, you're dealing with that degree of effort. So it becomes very problematic. At the same time, one needs to be extremely disciplined in their selection of how to design a trial to make sure you're going to get the most information out of that clinical trial and that investment of time and effort and money.
Yeah, what does that mean for your team when you're talking about the other people involved in this? You all had to be thrilled when you knew that you had some success with this, right?
Yeah, I mean, no more than me, but without question. I can't enough praise assigned to the individuals who have helped with this, and that's industry, institution, and it extends well beyond what I've been doing, and it's really been remarkable. But I will tell you that the shared enthusiasm and the drive comes from the inherent belief that we can do better, that we can cure other cancers in kids of the same age, but because the cancer affects a different organ, we shouldn't be satisfied with that. We should believe in that if we can cure one cancer, there's no reason we can't cure another cancer. But yes, it might involve a different strategy, and it might involve a much different technology. But the drive to do that is because of the belief that, one, we can do it and have done it, and two is to watch the grief and the suffering of these parents is an amazingly powerful motivation to do better. And for anyone who associates, and you mentioned you have friends with children who have been afflicted, if you listen and watch and understand what they go through, there's no greater motivation to do a better job and to improve the outcome for these kids. Congratulations,
Doctor, on the work that you're doing there, and to hear your passion is just absolutely phenomenal, wonderful. As you said, 15 years of work, the 4 years to complete. I can only imagine what a giant, giant effort. Dr. Mark Souweidane from Cornell Weill, thank you so much.
Oh, it's been my pleasure, but we're not finished. Until we consistently cure these children, then you can congratulate me, and I'll certainly accept that congratulations. I appreciate the time this morning.
I love it, Doc. Thank you so much.
Thank you as well.